Hello, people, and welcome to Med Novice, where we make tough medical stuff make sense. And the topic for today's discussion is diarrhea. So, how do textbooks define diarrhea? Is that if the patient has stool water content more than 200 milliliters per day, right? In that case, we will say that the patient has diarrhea. Another tool which can be used is this Bristol Stool Chart, wherein the stool is classified into seven different types, and based on these types, you can find out that what is the condition the patient is having, right? So, out of these seven types, type 6 and type 7, they are indicative of diarrhea. Whereas here, type 1 and type 2 are indicative of constipation. So what happens in type 6 stool? The stool has mushy consistency and ragged edges, right? Whereas in type 7 there is complete liquid consistency and there are no solid pieces. So this was a basic discussion about diarrhea, and now we will move towards the classification. First of all, diarrhea can be classified based on duration, right? So if diarrhea is presenting for less than 2 weeks, you say the patient has acute diarrhea. If it presents for somewhere between 2 to 4 weeks, then you say that the patient has persistent diarrhea. And if diarrhea is presenting for more than 4 weeks, then you say that the patient has chronic diarrhea. Right? Chronic diarrhea is something clinically quite concerning, whereas on the other hand, acute diarrhea is referred to as nuisance symptom by many. So acute diarrhea is referred to as nuisance symptom. So let's have a brief discussion here. It is referred to as nuisance symptom mainly because it is self-limiting. Right. So acute diarrhea is something self-limiting. Now what are the main causes of acute diarrhea? They are mainly the infectious agents, out of which the most common one is virus. Right. So viral infection is the most common cause for acute diarrhea. In case of adults, the most common virus that infects is norovirus. Whereas in case of children, it is rotavirus. So with this we complete our first discussion on the classification of diarrhea based on duration. Now moving to the second classification. Here the basis is the underlying pathology, right? So this is the pathology classification of diarrhea. Now let's say the patient has malabsorption, right? Let's say the patient has malabsorption. Now in case of malabsorption, there will be increased amount of unabsorbed nutrients within the lumen, right? So there will be increased amount of unabsorbed nutrients within the lumen, due to which the osmolality within the lumen will go high, or you can say that the osmotic load in the lumen increases, right? Now as the osmotic load within the lumen will increase, what will happen further is that it will draw in some water from the mucosa. So basically, as osmotic load goes up, what will happen is eventually that water will be drawn in from the mucosa towards the lumen, right? So what will happen is water enters the lumen from mucosa, due to which your stool water content will go up, which will ultimately result into diarrhea, right? So this is the first case wherein malabsorption resulted in increased amount of unabsorbed nutrients within the lumen, due to which the osmotic load went up, due to which water will enter lumen from mucosa, increasing the stool water content, ultimately resulting into diarrhea, right? Now as here the osmotic load went up, this diarrhea is known as osmotic diarrhea, right? So our first type of diarrhea in pathology classification is osmotic diarrhea, which is due to malabsorption. Now actually the hallmark of malabsorption is steatorrhea. What exactly steatorrhea is? Steatorrhea is the passing of pale, bulky, fatty, malodorous or greasy stools, right? So it is rare that patient will come and tell you that I found oily patches on the stool. But what is the most consistent clinical symptom of malabsorption? The most consistent clinical symptom of malabsorption is osmotic diarrhea, right? So this was a basic discussion on osmotic diarrhea. Now we will move to the investigations in osmotic diarrhea. So the investigations can either be qualitative, wherein you will be detecting the stool fat, right? Or it can be quantitative, wherein we will actually be measuring the stool fat. So in case of qualitative, you will be using stains which will be staining the stool fat. And what are those stains? The most common one is Sudan 3. Apart from Sudan 3, you can use Sudan 4 or oil red O. Right. So these are the stains which help you in qualitatively estimating, qualitatively detecting the stool fat. Right. Now we will move to the quantitative estimation. So we have a test called 72-hour fecal fat test. And this is the gold standard test for osmotic diarrhea. Right, this is the gold standard test for osmotic diarrhea. So what happens here is, basically, let's say this is the GIT of that person. So you give a fat input. You give a fat input of 100 grams per day, right? And this is given for 5 days. And then you measure the stool fat. How much stool fat is excreted, that is being measured, right? So, and this is mainly being measured on day 3, 4 and 5, right? So the stool fat excretion is being measured on day 3, 4, 5 and you give a fat input for 5 days of 100 grams per day, right? Now why we are selecting day 3, 4 and 5 particularly? This is mainly to average out all the variability present, right, in the results. So let's say before the patient came for investigation, he would have obviously consumed some food, right? That food would have some amount of fat, and that fat can change your results if you take the results on day 1 and 2. So that is the reason you choose day 3, 4 and 5 and you choose multiple days to average out the variability, right? Now if the stool fat excretion on these 3 consecutive days is less than 7 gram per day, then the patient is said to be normal, right? But if the stool fat excretion exceeds 7 gram per day, in that case you will say that the patient may present with osmotic diarrhea, right? There are chances that he has osmotic diarrhea. So this was the quantitative estimation or quantitative investigation for osmotic diarrhea. Now moving to the second type of diarrhea in pathological classification, that is secretory diarrhea, right? So what happens in secretory diarrhea is that you have an external agent, let's say you have an infective organism that will be releasing toxins, right? So either you have toxins or you have tumor within, let's say you have VIPoma, which will be releasing vasoactive intestinal peptide, and what they ultimately do is they activate some secondary mediator, right? They activate some secondary mediator which will lead to diarrhea, right? So due to this increase in the secondary mediator or due to the action of the secondary mediator, there will be secretion of different ions. For example, potassium will be secreted, right? Bicarbonate ions will be secreted, and water will be secreted. Water will be secreted in the result to these, right? Due to the resulting osmotic changes going on. So a toxin and tumor will come and they will activate the secondary mediator, and as a result, the stool water content will go up, ultimately resulting into diarrhea. So what are the possible toxins that can be a cause for the secretory diarrhea? It can be due to enterotoxigenic E. coli, that is ETEC, or Vibrio cholera, which is less common now, right? they release LT toxins. These guys release heat labile toxins, which are also known as LT toxins, and what they do is they increase the amount of cyclic AMP, due to which there are secretions ultimately leading to diarrhea. And what is the example for tumor? As we discussed, VIPoma, right? And in toxins, you can also have the enteropathogenic viruses acting as a toxin, right? They're capsid basically acting as a toxin. And which are those? They are rotavirus or norovirus. Okay. So this was a basic discussion on secretory diarrhea. Now, one thing to be seen here is that the toxins or tumor induce the action of the secondary mediator, and that will lead to diarrhea. But it should not be confused with some structural damage going on, right? So here in secretory diarrhea, we have no structural damage. We have no structural damage, right? This is one important point. Now, how does VIPoma present? The second fact, it presents as a triad. We can also remember it as WDHA syndrome, wherein WD stands for watery diarrhea, H stands for hypokalemia, right? As we know, different ions were being secreted, for example, potassium or bicarbonate, right? So it can result in hypokalemia and it can result in acidosis, right? So in case of VIPoma, you will see this classic triad, and in case of secretory diarrhea, there will be no structural damage seen. And what was the cause of secretory diarrhea? So these toxins, or let's say the substance released by a tumor, VIPoma, will ultimately lead to increase in CAMP, which is a secondary mediator that will lead to secretions and ultimately lead to diarrhea. So this was secretory diarrhea. Now let's say a patient presents to you with diarrhea. How will you differentiate that he has osmotic diarrhea or secretory diarrhea, right? So that is based on three parameters: osmotic diarrhea versus secretory diarrhea. So the first parameter to be discussed here is the stool osmotic gap, right? So what exactly is the stool osmotic gap? It is the measured osmolality of stool. It is measured using osmometer minus the expected osmolality, right? So normally the value of this measured osmolality is 100 milliosmoles per kg. And how do you calculate the expected osmolality? The calculation for expected osmolality is done using this formula, wherein you add the stool sodium and potassium concentration and basically multiply it with 2. So this is your stool osmotic gap, right? Now, the normal value for stool osmotic gap is 50 to 100 milliosmol per kg, right? This is the normal value for stool osmotic gap. Now what happened in osmotic diarrhea was that there was increase in the unabsorbed nutrients within the stool, right? So we can say that the concentration went up, hence the actual measured osmolality will go up, right? So you can remember it that the stool osmotic gap will go up in case of osmotic diarrhea, right? So it will be more than 100 milliosmoles per kg. Whereas in secretory diarrhea, what we saw is that there were secretions, right? There were secretions and potassium was being released, other ions were being released, due to which you can say that the expected osmolality went up. So as a result, you will see that the stool osmotic gap will go down, right? So it will be less than 50 milliosmoles per kg. So this was the discussion on the first parameter. Now let's see the second parameter. The second parameter is response to fasting, right? So basically, if we tell the person to fast, what he will do is he will not take food, right? Now if there is no nutrient then the question doesn't arise about whether the patient has malabsorption or not, right? Now, when there is no nutrient, there is no increase in the unabsorbed nutrient, and if there is no increase in the unabsorbed nutrient, there will be no increase in the osmotic load, due to which there will be no drawing in of water into the lumen from mucosa, right? Due to which the stool water content will not go up. So, in response to fasting, osmotic diarrhea will show improvement, right? So, osmotic diarrhea will show improvement in response to fasting. Whereas in case of secretory diarrhea, what will happen is that irrespective of whether you consume food or not, right, whether there are nutrients in the lumen or not, the toxin or the substance released by tumor is still present, right, and it is still activating the secondary mediators. So here you will see no response to fasting, right? There will be no improvement in case of secretory diarrhea, because here the etiological agent is yet present. But in case of osmotic diarrhea, the etiological agent itself was the nutrient, right? The agent was basically malabsorption. The cause was basically malabsorption. So there you saw improvement in response to fasting, right? Whereas in case of secretory diarrhea, there is no improvement in response to fasting. Now moving to the third parameter, that is stool pH. So what happens in case of osmotic diarrhea? You have some unabsorbed nutrient, right? And primarily from those unabsorbed nutrients, carbohydrates undergo fermentation by the gut microbiome, right? So if fermentation will take place of these unabsorbed carbohydrates, what will happen is that acids will increase, right? And as acids will increase, the stool pH will go down, right? So the stool pH decreases and it goes somewhere less than 5.5 in case of osmotic diarrhea. Whereas in case of secretory diarrhea, what we saw is that bicarbonate ions were being released in the stool, right? Now, if you know, there is an equilibrium going on in our body wherein the carbonic acid breaks into bicarbonate and gives us a proton, right? We know that the carbonic acid is a weak acid, and we also know that the conjugate of a weak acid will be a strong base, right? So you know that bicarbonate is a strong base, right? Now, if a strong base is entering your stool, what will happen to the stool pH? Obviously, the stool pH will go up, right? So it exceeds 6.0. If the stool pH is more than 6.0, you can say that it is secretory diarrhea. If it is going less than 5.5, you will be saying that it is osmotic diarrhea. So these were the main three parameters based on which we were differentiating osmotic diarrhea and secretory diarrhea, right? Now we will move to the final classification of diarrhea, and that is anatomical classification. Anatomical classification of diarrhea, this is based on the site where this pathology is taking place, right? The site where the pathology is taking place. Now it can be either in the small intestine or it can be in the large intestine, right? So it can be either in the small intestine, which you will be saying is a small intestinal diarrhea, and if it is in large intestine, then you will be saying that it is a large intestinal diarrhea, right? So what are the etiologies for small intestine diarrhea? It can be either osmotic, right? So basically the etiology will be malabsorption here, or it can be secretory. So the etiology in this case will be your toxins, right? It can be ETC or Vibrio cholera, right? So these are the etiological agents for small intestinal diarrhea. Whereas for large intestinal diarrhea, you can have infection, right? And infection by invasive organisms. For example, Shigella, right? So there can be infection by invasive organism, or large intestinal diarrhea can be due to inflammation, right? For example, in case of ulcerative colitis. So these were the causes for small intestinal diarrhea and large intestinal diarrhea. Now moving to the clinical presentation. See, we know that 90% of water is being absorbed within the small intestine, and the remaining water, some part of it gets absorbed in the large intestine, right? So if the small intestine will be affected, there will be more amount of water being released out in the stool, as there will be more amount of water that is going unabsorbed, right? Whereas in case of large intestinal diarrhea, already the absorption of water going on in the large intestine was relatively low as compared to going on in the small intestine. So if you have some problem going on there, yet you will not have that big volume of diarrhea, right? So you can say that the small intestine, or in case of small intestinal diarrhea, you have a large volume diarrhea. The volume of stool is large. Whereas in case of large intestinal diarrhea, the volume of stool is low. So it is a small volume diarrhea, right? So this was the discussion on volume. Now also one point to remember is that in case of small intestinal diarrhea, the frequency or urgency is less as compared to large intestinal diarrhea, right? This is another point. Now one important differentiator is presence of pus, blood and mucus. Pus, blood or mucus, right? Now pus, blood or mucus will be absent in case of small intestinal diarrhea, whereas it is present in case of large intestinal diarrhea. Why is it so? We clearly discussed in the topic of secretory diarrhea that there was no structural damage seen, right? The action was happening by the help of the secondary mediator, and there was no requirement of invasion, right? Whereas in case of large intestinal diarrhea, we have seen that the infection is due to invasive organism, due to which the structural damage will be seen, or it can be due to inflammation. So if it will be due to inflammation, you will find that pus is present within the stool. If it is due to this invasive organism, you will find out that blood or mucus is present within the stool, right? So pus, blood and mucus, these are present in large intestinal diarrhea, whereas these are absent in the small intestinal diarrhea, right? Now coming to another thing, tenesmus and dyschezia. Now what is tenesmus? Tenesmus is persistent and often painful sensation of needing to have a bowel movement or urinate, and even when your bowels or bladders are empty, right? So even when your bowels or bladders are empty, if you have a persistent and often painful sensation of needing to have a bowel movement or needing to urinate, right? So that will be referred to as tenesmus. Whereas what is dyschezia? Dyschezia is difficulty in passing stool, which is due to poor coordination between the abdominal and pelvic muscles, right? It is not due to constipation, right? You won't find hard stools. It is due to the poor coordination between the abdominal and pelvic muscles. So what we see is that tenesmus and dyschezia, these are present in case of large intestinal diarrhea, whereas these are absent in case of small intestinal diarrhea, right? So this is one another difference between these two. And now coming to weight loss, another differentiator. So as we know that small intestinal diarrhea was a large volume diarrhea, right? So there are more chances of weight loss in case of small intestinal diarrhea. So you will say that weight loss is present in small intestinal diarrhea, whereas it may be present in case of large intestinal diarrhea, but that is quite rare, right? So weight loss is rare in case of large intestinal diarrhea. So these were the main differences between small intestinal diarrhea and large intestinal diarrhea. Apart from this, you will say that abdominal pain and fever, these are present in case of large intestinal diarrhea, whereas these are absent in case of small intestinal diarrhea, right? This is another differentiator. And discussing about the abdominal cramps or bloating, so these are two things which will be present in both the cases, right? Abdominal cramps and bloating will be present in both small intestinal and large intestinal diarrhea, whereas abdominal pain and fever, these two will be present in large intestinal diarrhea, but they will be absent in small intestinal diarrhea. And with this we conclude our anatomical classification of diarrhea. And now we will move to let's say you have a patient coming to the clinics, then how you will approach the diarrhea, right? how you will approach the diarrhea. So let's develop a general paradigm for approach to diarrhea. Let's have a general paradigm here. So what you will do is, first the patient will present to you with diarrhea. First you will be seeing that how can you classify it based on duration, right? After that you will see that what is the site of the underlying pathology. So you will look towards the anatomical classification, and then by the help of pathological classification you will find the actual underlying cause, right? This is how you approach diarrhea in clinics. So let's say the patient presented to you with diarrhea. So you will first ask what for how long the diarrhea has been there, right? So based on duration, either it can be less than 2 weeks or it can be more than 4 weeks, right? So if the diarrhea is acute, then according to our paradigm, next question we will be asking is about the anatomical classification. So basically you will be seeing whether the patient has fever, whether the patient has pain in abdomen, right? Or whether the stool is having blood or mucus. If these are present, then you will say that the patient is having large intestinal diarrhea, right? Whereas if these are absent, you will say that the patient has small intestinal diarrhea, right? So based on fever, pain and abdominal pain and presence of blood and mucus in stool, you will classify it into small intestinal or large intestinal diarrhea. Now if the patient is having acute diarrhea and it is of the small intestinal type, right, which is the large volume diarrhea, then what can be the causes? The most common cause in that case will be viral. So viral cause is most common if the small intestinal diarrhea is acute, right? Apart from it, you can see diarrhea due to enterotoxigenic E. coli. It can be due to Vibrio cholera, right? These can be the causes, and this will be self-limiting, right? Now if the patient has acute diarrhea and he is presenting with small volume diarrhea, or let's say fever, pain in abdomen, blood or mucus in stool, then in that case what can be the cause? The cause will be invasive organism, right? The cause will be invasive organism. And which are those invasive organisms? It can be Shigella, it can be Campylobacter, it can be non-typhoid Salmonella, right? These can be the possible causes in that case. Now moving to the second part, the chronic part, right? So if the patient is telling that he had diarrhea for more than 4 weeks, again based on pain in abdomen, fever or presence of blood or mucus in stools or the volume of diarrhea, you will classify him into a small intestinal diarrhea and a large intestinal diarrhea. Now discussing the chronic causes for small intestinal diarrhea, it can be either malabsorption leading to osmotic diarrhea, or it can be secretory diarrhea due to tumor, right? So for chronic small intestinal diarrhea, the causes can be malabsorption, right? And it can be secretory diarrhea due to tumor, which is VIPoma. Okay, how you will check whether it is osmotic? You will check the stool osmotic gap, right? You will check the stool osmotic gap. Also you will see the response to fasting. This will help you differentiate between osmotic or secretory cause, right? So by this way you can reach the ultimate cause lying behind that diarrhea. Now if it is of the large intestinal type, it may be due to invasive organism, but more likely one more cause which can be included in case of a chronic large intestinal diarrhea is the inflammatory cause, right? For example, in case of ulcerative colitis. So this was the approach to diarrhea. Let's revise it once again. So let's say the patient comes to you with diarrhea. You will follow this paradigm wherein you will first ask the patient about the duration of diarrhea, for how long the diarrhea has been, and then you will move to the anatomical classification, right? You will see whether the patient has fever, whether the patient has abdominal pain. You will check for the volume of diarrhea, whether it is small volume or large volume, right? You will check for pus, blood or mucus present in the stool, right? And if pus, blood or mucus is present in the stool, you will classify it as large intestinal diarrhea. If it is not present, you will classify it as small intestinal diarrhea. Now, if you are talking about the acute presentation, and if you have seen that the patient is having small intestinal diarrhea, what can be the common causes? The most common cause is the viral cause, right? Which can be due to enteropathogenic virus, which is norovirus or rotavirus, right? Or it can be due to enterotoxigenic E. coli, or it can be due to Vibrio cholera, and this condition is mainly self-limiting. But if the acute presentation is of large intestinal diarrhea, then the cause is a bit concerning, and that is invasive organism, right? So there might be invasion of the lining of large intestine. And what are those organisms? It can be either Shigella, it can be Campylobacter, or it can be non-typhoid Salmonella. Now, if the patient is presenting with chronic diarrhea, again based on those same parameters, you will divide it into small or large intestinal diarrhea. Now, discussing about the chronic causes for small intestinal diarrhea, it can be either malabsorption, or it can be tumor leading to secretory diarrhea, that is VIPoma, right? Now, how you will differentiate and how you will reach to the ultimate cause? So you will be checking for the stool osmotic gap, which will be going above 100 milliosmoles per kg in case of osmotic diarrhea, and it will remain below 50 milliosmoles per kg in case of secretory diarrhea. Otherwise, you can check response to fasting, wherein osmotic diarrhea will show improvement in response to fasting, whereas the secretory diarrhea will show no improvement in response to fasting. So based on this, you can reach to the cause, whether it is malabsorption or VIPoma. And if the chronic presentation is of large intestinal diarrhea, one cause which you should not forget to look for is the inflammatory cause, right? And what can be a case of inflammatory cause leading to a chronic large intestinal diarrhea? It can be ulcerative colitis. So with this, we conclude our discussion on diarrhea, and I hope this video helped you. If this video helped you, don't forget to like, share and subscribe. This is Med Novice, learning medicine the simpler way. Thank you.